My name is Tom Hutson. I am the director of the GU Oncology program with Texas Oncology at Baylor Sammons Cancer Center, where I also co-chair the Urologic Cancer Research and Treatment Center. I'm a professor of medicine at Texas A&M College of Medicine, and I run the Early Development Phase 1 program for Sarah Cannon Research Institute. Renal cell carcinoma is the most common cancer of the kidney, such that when patients say they have kidney cancer, they invariably mean they have renal cell carcinoma. So renal cell carcinoma is AKA kidney cancer, but it's the predominant form. It's what patients would equate when you use the word kidney cancer, and it's its own disease. And like it's being its own disease, it has its own natural history. It has its own various genetic abnormalities that we're discovering and its own responses to various therapies. When I am discussing with the patient the stage of their cancer, we discuss whether or not it's in a localized state, which could be potentially cured with surgical intervention. Sometimes if a patient is not a candidate for surgery, we can do a non-surgical intervention such as an ablation of the kidney mass, or as it moves into that stage 3 or stage 4, which is really by definition a tumor which is now starting to grow outside the confines of the kidney, or in the setting of stage 4 has spread beyond the kidney to other organs. In that situation, the cancer can be much more difficult to cure. We can still sometimes remove the cancer surgically from the kidney, but oftentimes we must do other things, provide other types of therapies. When we use the words advanced cancer, we usually mean it's stage 3 or stage 4. When we refer to the cancer as being incurable or metastatic, we usually mean stage 4. Advanced renal cell carcinoma is a state of the cancer where it has displayed more aggressive features, such as invasion into the renal vein, invasion into the inferior vena cava, extension into and sometimes through the fascial coverings of the kidney, and in the state of metastatic disease has spread to other organs. That state is generally considered not curable. When I'm first meeting a patient that has been diagnosed with kidney cancer, obviously they're quite anxious. And so one of the first things I have to do is read the room and see where they are in their understanding of the disease process. Sometimes they come in already having an understanding that their cancer may or may not be curable, and they'll have an understanding from the urologist, which is the surgeon, whether or not surgical options are even possible. Other times, I'm the one who has to share that news with them. Some of the challenges when making a treatment choice for patients with advanced RCC is really individualizing that therapy to the patient sitting in front of you. So patients bring into them their own histories, their own medical histories, comorbidities, their own goals of therapy. So we essentially want to look at a couple different things. We want to look at the pathology and what the tumor is in that individual patient. Is it highly metastasized and spread to multiple areas of the body? So that's what I consider one area to look at. Then we need to look at specifically the patient. What could they handle? Is this a patient that is frail, where they're going to be not a patient that can handle much side effects? Where are they at in their life? What other medical conditions are they dealing with that could hinder or hamper aggressive therapy? And what are the goals of the patient? Some patients, especially those that may be young, are going to be wanting to be more aggressive, especially if they have young children at home. Other patients may be older in age and they've been dealing with other medical conditions, and their focus is going to be on disease control and with the least amount of side effects possible. So it really, you have to take your experience, what the science tells us about the disease, the natural history of the disease, the various treatment options, the outcomes of that, what you've learned as a physician taking care of patients. Renal cell carcinoma is just a basket term and really is a type of cancer of which there are many subtypes. There are at least 5 major types that we see in practice. The most common type is something called clear cell, which we see in 80-85% of patients. And that's the type that's been the predominant type studied in the clinical trials, and the one in which all the approved therapies have shown efficacy. And so knowing exactly what type they have is going to help us as we try to prognosticate to the patient on what their outcome choices are going to be. Then we need to look at things like the patient themselves. What are their comorbidities? What's the age of the patient? This is where the goals of the patient become important. And sometimes asking and having a dialogue with the patient and the family after they know the extent of their disease and what they're facing, what are their goals? So these factors will come in and we'll make a decision, usually during that first meeting, what direction to go. I'll be looking at all of the different testing that's been done and make a determination. Do I need to order any additional testing to determine the extent of the disease or their tolerance to therapy? And then we'll generally embark on some type of treatment plan for them. Not all patients make it to first-line therapy, but the majority of them do. And they'll be on that therapy for any given amount of time. It can be just a few months, it could be a few years, but ultimately, the majority of these patients would progress on that therapy and would be candidates to move into the second-line setting. The studies that we have done have shown us that there is an attrition of patients as we move from first to second to third to fourth to fifth line. So evidence would suggest that there's roughly only 93% of patients that make it into first line. So right away from the get-go, 7% of patients are not even getting into frontline therapy for a variety of reasons. Some of that would be death, some of that would be worsening medical conditions, going on hospice, change of mind of how aggressive they want to be, etc. When we move from that first line into the second line, we have an attrition of patients again that may have succumbed to the illness and for whatever reason don't make it into second line upon progression. And that is estimated to be roughly 71% of patients. And likewise, as we move in from that second line to the third line, we're down to only 41% of patients. And finally, when we get down to the fourth line setting, we're only left with roughly 16% of the patients that we started with making it there. Again, as a clinician, I like to look at my patients and think I do better than that, and that all of my patients that are progressing in one line make it into the next line, but we have to realize that that's not the case. And so this has been a fundamental shift in our understanding, and we really need to stress to those treating patients with kidney cancer to not save therapy to later. So that has really changed the way I approach the treatment. I'm looking at patients, and the vast majority of my patients are going to receive what I believe is the most active regimen for them. And I'm only going to not do that in rare cases where I'm really concerned about the tolerance of an individual patient. Adverse reactions, some of which can be serious or fatal, may occur with LENVIMA, including hypertension, cardiac dysfunction, arterial thromboembolic events, hepatotoxicity, renal failure or impairment, proteinuria, diarrhea, fistula formation and gastrointestinal perforation, QT interval prolongation, hypocalcemia, reversible posterior leukoencephalopathy syndrome, hemorrhagic events, impairment of thyroid-stimulating hormone suppression, thyroid dysfunction, impaired wound healing, osteonecrosis of the jaw, and embryo-fetal toxicity. Based on its mechanism of action and data from animal reproduction studies, LENVIMA can cause fetal harm when administered to a pregnant woman. Females of reproductive potential should be advised to use effective contraception. Based on the severity of the adverse reaction, LENVIMA should be interrupted, reduced, and/or discontinued. As with any medication, it's important to review the adverse reactions in the prescribing information. It is important to note that most patients will need dose modification strategies as guided by the prescribing information to help manage adverse reactions during their treatment journey.
Indication: LENVIMA, lenvatinib, is indicated in combination with everolimus for the treatment of adult patients with advanced renal cell carcinoma, RCC, following one prior anti-angiogenic therapy. Important safety information, warnings and precautions. Hypertension. In DTC, differentiated thyroid cancer, hypertension occurred in 73% of patients on LENVIMA. In RCC, renal cell carcinoma, hypertension occurred in 42% of patients on LENVIMA and everolimus. Systolic blood pressure greater than or equal to 160 millimeters of mercury occurred in 29% of patients, and 21% had diastolic blood pressure greater than or equal to 100 millimeters of mercury. In HCC, hepatocellular carcinoma, hypertension occurred in 45% of LENVIMA-treated patients. Grade 4 hypertension was not reported in HCC. Serious complications of poorly controlled hypertension have been reported. Control blood pressure prior to initiation. Monitor blood pressure after 1 week, then every 2 weeks for the first 2 months, and then at least monthly thereafter during treatment. Withhold and resume at reduced dose when hypertension is controlled, or permanently discontinue based on severity. Cardiac dysfunction. Serious and fatal cardiac dysfunction can occur with LENVIMA. Across clinical trials in 799 patients with DTC, RCC, and HCC, grade 3 or higher cardiac dysfunction occurred in 3% of LENVIMA-treated patients. Monitor for clinical symptoms or signs of cardiac dysfunction. Withhold and resume at reduced dose upon recovery or permanently discontinue based on severity. Arterial thromboembolic events. Among patients receiving LENVIMA or LENVIMA plus everolimus, arterial thromboembolic events of any severity occurred in 2% of patients in RCC and HCC and 5% in DTC. Grade 3 through 5 arterial thromboembolic events ranged from 2% to 3% across all clinical trials. Among patients receiving LENVIMA with pembrolizumab, arterial thrombotic events of any severity occurred in 5% of patients in CLEAR, including myocardial infarction 3.4% and cerebrovascular accident 2.3%. Permanently discontinue following an arterial thrombotic event. The safety of resuming after an arterial thromboembolic event has not been established, and LENVIMA has not been studied in patients who have had an arterial thromboembolic event within the previous 6 months. Hepatotoxicity. Across clinical studies enrolling 1,327 LENVIMA-treated patients with malignancies other than HCC, serious hepatic adverse reactions occurred in 1.4% of patients. Fatal events, including hepatic failure, acute hepatitis, and hepatorenal syndrome, occurred in 0.5% of patients. In HCC, hepatic encephalopathy occurred in 8% of LENVIMA-treated patients. Grade 3 through 5 hepatic failure occurred in 3% of LENVIMA-treated patients. 2% of patients discontinued LENVIMA due to hepatic encephalopathy, and 1% discontinued due to hepatic failure. Monitor liver function prior to initiation, then every 2 weeks for the first 2 months, and at least monthly thereafter during treatment. Monitor patients with HCC closely for signs of hepatic failure, including hepatic encephalopathy. Withhold and resume at reduced dose upon recovery or permanently discontinue based on severity. Renal failure or impairment. Serious, including fatal renal failure or impairment, can occur with LENVIMA. Renal impairment was reported in 14% and 7% of LENVIMA-treated patients in DTC and HCC, respectively. Grade 3 through 5 renal failure or impairment occurred in 3% of patients with DTC and 2% of patients with HCC, including 1 fatal event in each study. In RCC, renal impairment or renal failure was reported in 18% of LENVIMA plus everolimus-treated patients. Initiate prompt management of diarrhea or dehydration hypovolemia. Withhold and resume at reduced dose upon recovery, or permanently discontinue for renal failure or impairment based on severity. Proteinuria. In DTC and HCC, proteinuria was reported in 34% and 26% of LENVIMA-treated patients, respectively. Grade 3 proteinuria occurred in 11% and 6% in DTC and HCC, respectively. In RCC, proteinuria occurred in 31% of patients receiving LENVIMA plus everolimus. Monitor for proteinuria prior to initiation and periodically during treatment. If urine dipstick proteinuria greater than or equal to 2+ is detected, obtain a 24-hour urine protein. Withhold and resume at reduced dose upon recovery or permanently discontinue based on severity. Diarrhea. Of the 737 LENVIMA-treated patients in DTC and HCC, diarrhea occurred in 49%. In RCC, diarrhea occurred in 81% of LENVIMA and everolimus-treated patients. Diarrhea was the most frequent cause of dose interruption reduction, and diarrhea recurred despite dose reduction. Promptly initiate management of diarrhea. Withhold and resume at reduced dose upon recovery or permanently discontinue based on severity. Fistula formation and gastrointestinal perforation. Of the 799 patients treated with LENVIMA or LENVIMA plus everolimus in DTC, RCC, and HCC, fistula or gastrointestinal perforation occurred in 2%. Permanently discontinue in patients who develop gastrointestinal perforation of any severity or grade 3 through 4 fistula. QT interval prolongation. In DTC, QT/QTC interval prolongation occurred in 9% of LENVIMA-treated patients, and QT interval prolongation of greater than 500 milliseconds occurred in 2%. In RCC, QTC interval increases of greater than 60 milliseconds occurred in 11% of patients receiving LENVIMA plus everolimus, and QTC interval greater than 500 milliseconds occurred in 6%. In HCC, QTC interval increases of greater than 60 milliseconds occurred in 8% of LENVIMA-treated patients, and QTC interval greater than 500 milliseconds occurred in 2%. Monitor and correct electrolyte abnormalities at baseline and periodically during treatment. Monitor electrocardiograms in patients with congenital long QT syndrome, congestive heart failure, bradyarrhythmias, or those who are taking drugs known to prolong the QT interval, including Class 1A and 3 antiarrhythmics. Withhold and resume at reduced dose upon recovery based on severity. Hypocalcemia. In DTC, grade 3 through 4 hypocalcemia occurred in 9% of LENVIMA-treated patients. In 65% of cases, hypocalcemia improved or resolved following calcium supplementation with or without dose interruption or dose reduction. In RCC, grade 3 through 4 hypocalcemia occurred in 6% of LENVIMA and everolimus-treated patients. In HCC, grade 3 hypocalcemia occurred in 0.8% of LENVIMA-treated patients. Monitor blood calcium levels at least monthly and replace calcium as necessary during treatment. Withhold and resume at reduced dose upon recovery or permanently discontinue depending on severity. Reversible posterior leukoencephalopathy syndrome, RPLS. Across clinical studies of 1,823 patients who received LENVIMA as a single agent, RPLS occurred in 0.3%. Confirmed diagnosis of RPLS with MRI. Withhold and resume at reduced dose upon recovery or permanently discontinue depending on severity and persistence of neurologic symptoms. Hemorrhagic events. Serious, including fatal hemorrhagic events can occur with LENVIMA. In DTC, RCC, and HCC clinical trials, hemorrhagic events of any grade occurred in 29% of the 799 patients treated with LENVIMA as a single agent or in combination with everolimus. The most frequently reported hemorrhagic events were epistaxis and hematuria. In DTC, grade 3 through 5 hemorrhage occurred in 2% of LENVIMA-treated patients, including one fatal intracranial hemorrhage among 16 patients who received LENVIMA and had CNS metastases at baseline. In RCC, grade 3 through 5 hemorrhage occurred in 8% of LENVIMA plus everolimus-treated patients, including one fatal cerebral hemorrhage. In HCC, grade 3 through 5 hemorrhage occurred in 5% of LENVIMA-treated patients, including 7 fatal hemorrhagic events. Serious tumor-related bleeds, including fatal hemorrhagic events, occurred in LENVIMA-treated patients in clinical trials and in the post-marketing setting. In post-marketing surveillance, serious and fatal carotid artery hemorrhages were seen more frequently in patients with anaplastic thyroid carcinoma, ATC, than other tumors. Safety and effectiveness of LENVIMA in patients with ATC have not been demonstrated in clinical trials. Consider the risk of severe or fatal hemorrhage associated with tumor invasion or infiltration of major blood vessels, example, carotid artery. Withhold and resume at reduced dose upon recovery or permanently discontinue based on severity. Impairment of thyroid-stimulating hormone suppression, thyroid dysfunction. LENVIMA impairs exogenous thyroid suppression. In DTC, 88% of patients had baseline thyroid-stimulating hormone (TSH) level less than or equal to 0.5 milliunits per liter. In patients with normal TSH at baseline, elevation of TSH level greater than 0.5 milliunits per liter was observed post-baseline in 57% of LENVIMA-treated patients. In RCC and HCC, grade 1 or 2 hypothyroidism occurred in 24% of LENVIMA plus everolimus-treated patients and 21% of LENVIMA-treated patients, respectively. In patients with normal or low TSH at baseline, elevation of TSH was observed post-baseline in 70% of LENVIMA-treated patients in HCC and 60% of LENVIMA and everolimus-treated patients in RCC. Monitor thyroid function prior to initiation and at least monthly during treatment. Treat hypothyroidism according to standard medical practice. Impaired wound healing. Impaired wound healing has been reported in patients who received LENVIMA. Withhold LENVIMA for at least 1 week prior to elective surgery. Do not administer for at least 2 weeks following major surgery and until adequate wound healing. The safety of resumption of LENVIMA after resolution of wound healing complications has not been established. Osteonecrosis of the jaw, ONJ. ONJ has been reported in patients receiving LENVIMA. Concomitant exposure to other risk factors such as biphosphonates, denosumab, dental disease, or invasive dental procedures may increase the risk of ONJ. Perform an oral examination prior to treatment with LENVIMA and periodically during LENVIMA treatment. Advise patients regarding good oral hygiene practices and to consider having preventative dentistry performed prior to treatment with LENVIMA and throughout treatment with LENVIMA. Avoid invasive dental procedures if possible while on LENVIMA treatment, particularly in patients at higher risk. Withhold LENVIMA for at least 1 week prior to scheduled dental surgery or invasive dental procedures if possible. For patients requiring invasive dental procedures, discontinuation of biphosphonate treatment may reduce the risk of ONJ. Withhold LENVIMA if ONJ develops and restart based on clinical judgment of adequate resolution. Embryo-fetal toxicity. Based on its mechanism of action and data from animal reproduction studies, LENVIMA can cause fetal harm when administered to pregnant women. In animal reproduction studies, oral administration of lenvatinib during organogenesis at doses below the recommended clinical doses resulted in embryo-toxicity, fetotoxicity, and teratogenicity in rats and rabbits. Advise pregnant women of the potential risk to a fetus and advise females of reproductive potential to use effective contraception during treatment with LENVIMA and for 30 days after the last dose. Adverse reactions. In RCC, The most common adverse reactions observed in LENVIMA and everolimus treated patients were diarrhea, fatigue, arthralgia, myalgia, decreased appetite, vomiting, nausea, stomatitis, hypertension, peripheral edema, cough, abdominal pain, dyspnea, rash, decreased weight, hemorrhagic events, and proteinuria. The most common serious adverse reactions were renal failure, dehydration, anemia, thrombocytopenia, diarrhea, vomiting, and dyspnea. Adverse reactions led to dose reductions or interruption in 89% of patients. The most common adverse reactions resulting in dose reductions were diarrhea, fatigue, thrombocytopenia, vomiting, nausea, and proteinuria. Treatment discontinuation due to an adverse reaction occurred in 29% of patients. Use in specific populations. Because of the potential for serious adverse reactions in breastfed children, advise women to discontinue breastfeeding during treatment and for 1 week after the last dose. LENVIMA may impair fertility in males and females of reproductive potential. No dose adjustment is recommended for patients with mild or moderate renal impairment. LENVIMA concentrations may increase in patients with DTC, RCC, or EC, endometrial carcinoma, and severe renal impairment. Reduce the dose for patients with DTC, RCC, or EC and severe renal impairment. There is no recommended dose for patients with HCC and severe renal impairment. LENVIMA has not been studied in patients with end-stage renal disease. No dose adjustment is recommended for patients with HCC and mild hepatic impairment, child Pug A. There is no recommended dose for patients with HCC with moderate child Pug B or severe child Pug C, hepatic impairment. No dose adjustment is recommended for patients with DTC, RCC, or EC and mild or moderate hepatic impairment. LENVIMA concentrations may increase in patients with DTC, RCC, or EC and severe hepatic impairment. Reduce the dose for patients with DTC, RCC, or EC and severe hepatic impairment. For more information about LENVIMA, please see available full prescribing information.